Good morning, everyone. Good morning. Thank you. Some people got the cue. We're about to start here in a minute, but before we do, I just want to acknowledge and thank some people who have been instrumental in getting this third annual Rural Healthcare Symposium off the ground. First and foremost, Dean Rutledge, you'll hear in the moment, has been supportive of this initiative from the get-go. When Bill Boling and I, you'll hear from in a moment, kind of approaching this idea of addressing this issue, which now is part of the national conversation. You know, what should we do about all these rural hospitals closing, related effects such as substance abuse addiction, lack of access to behavioral health, et cetera. We were ahead of the curve on that, unfortunately, and it's still an issue that needs to be addressed. But from the get-go, Bo was like, what do you need? We support this. This is an important mission for us. And related to that, Heidi Murphy, who's sitting right next to him in our communications department, we couldn't do this event without her, getting the word out, letting people know that this is what we're doing. Lisa Mathis, if she's here, she's not. Lisa, thank you so much. Thank you so much for kind of putting together all the logistical support. We couldn't do this event without you. Mason Reed, special thank you, associate at Boling and Company. Every year, Bill and I have the same conversation. Thank God for Mason. We couldn't do this without him. And I want to brag on Mason a little bit because he was a former student of mine, also a student of Bill's when Bill was teaching as an adjunct. And I'd like to take credit for the success he's had, but I really can't. But he has an even more important event coming up in Athens next week. Even more important than the Rural Healthcare Symposium. He's getting married. So thank you, Mason. And of course, my co-conspirator, Bill Boling. This event really started as a conversation when Bill approached me and said, look, I'm going through all these communities in Georgia. And it's not, he didn't say my clients. There were his clients, but he also said, you know, these are people, these are real communities that are hurting, and we need to do something to address and highlight those challenges, and also maybe bring together people from different areas, different disciplines, to break through these silos where we're not talking to each other about potential solutions to how do we address these challenges. So thanks again, Bill. I consider a dear friend and colleague. But with that, I want to introduce Dean Rutledge, who we're very fortunate to have to come here as faculty, and I can speak for hours about Bo's accolades, but I'll just turn over the mic to him, and he'll give some opening remarks.
Well, thank you all, and welcome to Athens. I sometimes worry that the role of the dean is to interrupt pleasant conversation before injecting a serious topic into the room and then dashing off to a meeting with the provost. Two of those things may be true today, but it's such an honor for us to be hosting the third annual Rural Healthcare Symposium. The state of Georgia has been described as ground zero for rural hospital closures and challenges of access to care. And as your state's flagship institution, part of our duty is to address matters of profound importance to the state, and in doing so, help shape an issue that transcends state boundaries and is of national significance. At this law school, we honor that commitment through our mission, which is encapsulated in three simple words that are exemplified by today's conference. And those words are prepare, connect, and lead. The goal of a law school is to ensure that our graduates receive a quality education that gives them a foundation to have an impact on society. And here at the University of Georgia, we have sought to honor that commitment inside and outside the classroom. Inside the classroom, we're privileged to have two incredibly fine law professors who teach at the intersection of law and health. Dr. Fazl Khan, whom you just heard from, and our colleague, Professor Elizabeth Weeks-Leonard. And to have a law school with two incredibly dedicated, credentialed, accomplished faculty members helps us prepare those students. And outside the classroom, at a time when law schools are having to sort of shutter or reduce their commitment to experiential learning, we've expanded ours. We have 17 different clinical and experiential programs here at the law school, including a medical legal partnership that takes the view that oftentimes the intersection that somebody has with the social safety net in a society begins somewhere in the medical community, but the underlying cause and the underlying solution may lie with law. And so our Professor Jason Cade has built a network of relationships with medical care providers so that as patients present themselves with needs, the doctor's help doesn't end with prescribing treatment, but referring them to someone who can provide free legal assistance to improve their lives. Our child sex abuse clinic similarly develops relationships between those who present medical issues with underlying legal solutions. In this fall, we will launch the state's first full-time in-house Veterans Legal Services Clinic to serve those who have served their country in claims with the government. I'm especially pleased that many of the students who have participated in these opportunities to prepare have helped today. That takes me to the second part of our mission, Connect. I have some statements that I could say about Connect, but I look at Mason, and I think Mason is the embodiment of our mission. You take a student in the classroom, expose him to professors, expose him to thought leaders, and through the relationships that are built, launch him into a profession where he can come back to his alma mater and have an instrumental role in his issues and in shaping the debates and the issues that he cares about. I didn't mean connect in the sense of introducing you to your wife, but connect in the sense, and I say that quite seriously. A few weeks ago, we had a similar conference here focused on environmental law and disaster recovery. And what was striking about it was that some of the students who had participated in that program in the past, as a result of the relationships that were built there, went on after the program and made presentations to national, in some cases international policymaking audiences because of conversations that began in conferences like this. So as to the mission of Connect, I would ask each of you in the room to seek out our students, not only with the hope that you can help produce another Mason, but also to recognize that one of the great assets, one of the great virtues of an institution of higher education is the enthusiasm, the time, the dedication, and the commitment that our students bring to events like these. It's the sweat equity that they put in to make these events successful, and they can help each of you in that mission. And lead. We are a community of leaders, whether they are leaders in government, leaders in the bar, leaders in business, leaders in their communities. And part of being a leader is taking on tough challenges. Rural healthcare is one of those. And today's symposium is about an effort to bring together leaders and breaking down the kind of silos that stand in the way of interdisciplinary and interprofessional innovation. My hope is that today will advance potential solutions, connect today's leaders with tomorrow, and promote collaborations among those who are committed to addressing the health and civic needs of our rural communities at ground zero. I'm thankful to Dr. Kahn, Professor Weeks, our alums, Bill Boling and Mason Reed, for their visionary leadership in bringing this conference to our campus. And as I said to Bill and Dr. Kahn a short while ago, our door is always open to you. So with that, I give you Bill Boling.
Well, we've got some terrific experts and thought leaders in the room, and so I'll keep my remarks very brief. I want to, there's so many people to thank, and I'm not going to be able to thank you all, but it cannot be said enough that without the University of Georgia, and particularly the support of Dr. Professor Kahn and Professor Elizabeth Weeks, we would not be here today. Fazil's exactly right. This began, I believe it was probably a conversation over beer. It could have been coffee, probably beer, probably creature comforts. It was at a time when, as I'd left the world of big law firms so that I could focus more on community hospitals, the work that I really, really love, this has started 5-6 years ago, and I was just seeing a rising tide of difficulty and a rising tide of real hurt. I think at the time we were tied for second with Alabama for the most hospital foreclosures. So we had 6 in a period of just few years. It was, and it still is, you're going to hear from some of our in the trenches panelists just how challenging and frankly grim in many instances the efforts to save these hospitals are. What is not as clear, perhaps, but some of our partners here know, and will speak to this, is how not only grim, but how vastly important it is for the success of our state as a whole. I'm from Lindale, Georgia. I'm a proud graduate of Pepperell High School. I came and interviewed with former Secretary of State Dean Rusk, who's also from North Georgia, and he talked me into coming to law school here. He was a pretty persuasive gentleman. Ironic that we find ourselves in a building named after him and all that he did, but he was also not from the Atlanta area, and it's the people outside of Atlanta often that are leading the state, but often get forgotten. They're forgotten, and not for wrong reasons, or not for bad reasons, just because the energy of communication usually goes to the biggest markets. And so to have a setting in Athens, Georgia, outside of the Atlanta penumbra, for us to be able to come together, thought leaders that you are, and as I look around the room, I realize that it's this gathering, a strong, powerful gathering of people cross-disciplinary who are leaders in each of their respective fields. It's an honor to be here at the land-grant institution for the entire state. I have to acknowledge quickly a few people that are also, we would not be able to do this without them. First and foremost is Healthcare Georgia Foundation, whose generous grant allows us to actually pull together to pay for travel and other expenses associated with bringing people in. Dr. Gary Nelson and his colleague Samantha Tucker, who's going to, is Samantha here? Samantha, I think, will make a couple of remarks about Healthcare Georgia's mission before we kick off. They just do so much, and many of you here are beneficiaries of either their grants or all of the efforts that they make to communicate. And communication is leadership, and no one does more or does it better in as many different venues as Healthcare Georgia Foundation. Private companies like Boling and Company are also necessary members of the conversation. We contribute money and time and energy and efforts, and 3 others that have stepped up this year with that and money is Azalea Health, an electronic medical records company that started in Valdosta, Georgia. Go Valdosta. And has now grown into one of the largest companies of its kind in the Southeast and growing nationally. AB Risk, another company, Amy and Keith Becker founded that company, and they're in Barrow County, right next door. And they have a worldwide practice in risk management solutions and are very close to the ground, supporting many community hospitals that we work with. And finally, Stroudwater Associates, who I've been privileged to work with for many years now, doing affiliation work and other types of hospital turnaround work with a big focus in the community hospital space. We could not be bringing this to you today without their support. Your brochure will say that someone else from Healthcare Georgia is going to be speaking. That's wrong. We've had the good fortune of having Samantha here with us today. And before we kick off our first panel, Samantha, would you come and tell folks a little bit about Healthcare Georgia and what you do?
Thank you, Bill. My name is Samantha Tucker, and I am the Evaluation Manager for Healthcare Georgia Foundation. All right. As you've already heard this morning, we're here today because we understand that health and healthcare in rural Georgia is in a dire state. Rural Georgia communities are losing their capacity to deliver the right care at the right time and at the right place. And Healthcare Georgia Foundation would like to thank Boling and Company and the University of Georgia School of Law for designing and putting on this annual event that brings together some of the brightest minds to help solve this problem. So thank you all. For the next few minutes, I'd like to talk a little bit about what Healthcare Georgia is doing with regards to rural Georgia. Where do I click? Oh, there it is. Okay. Because health disparities have become a substantially place-based issue, Healthcare Georgia is committed to taking the pulse and temperature of rural Georgians with the fundamental belief that in the midst of difficulty lies opportunity for greater health equity. The Health Voices, Health and Healthcare in Rural Georgia series seeks to reveal rural Georgians' personal experience with healthcare, unique local healthcare issues, and perceptions regarding responsibility for rural healthcare. The Foundation first provided support to Opinion Savvy in 2015 to conduct this public opinion survey, and again in 2016 and 2017. The results from these surveys confirmed what was observed. There is a significant health penalty for living in rural Georgia. More rural Georgians are reporting personally experiencing barriers in accessing healthcare services. Over time, access to care has become more important relative to cost of care. Copies of the 2016 Health Voices, Health and Healthcare in Rural Georgia are on the registration table, along with the 2017 Health Voices infographic. The actual publication should be available on the Foundation's website, hopefully in May of this year. So I hope you all find those interesting. In 2016, Healthcare Georgia awarded Georgia Southern's College of Public Health to identify and describe strategies adopted by rural hospitals to improve financial stability and assess the perceived effectiveness of these strategies. Dr. Betty Appentang and her team surveyed rural hospitals in the state, as well as a sample of rural hospitals nationally. They found that the most common strategies adopted by rural hospitals for the purpose of improving financial performance included improving patient satisfaction and care experience, where the overall adoption rate was 91%, and the addition of new service lines or expansion of existing services had an adoption rate of 83%. And again, there are one-pagers on the table, on the registration table. I figured this would be very beneficial for the audience here since it's positioning rural hospitals for financial sustainability. And if you want to read the 67-page full report, you can contact Dr. Betty Appentang, whose contact information is on that one-pager. Or me, it doesn't matter, we'll get it to you. So in June of 2017, Healthcare Georgia Foundation awarded $770,000 in grants to 11 organizations listed that lead the Two Georgias Initiative Phase 1 Community Health Partnerships. The goal of the Two Georgias Initiative is to foster healthcare innovation by supporting local partnerships seeking to improve health and expand access to quality healthcare services in Georgia's rural communities. Next week, the partnerships will be submitting a 3 to 5 year community health improvement plan, which includes an extensive evaluation plan looking at health equity metrics and what we can really measure over time, and also a logic model. So I had to add that little plug in for all of the people that love evaluation. Over the course of the next few years, each community health partnership stands to benefit from more than $500,000 in foundation funding and technical resources through the initiative to support their work. And we have some of the partnerships here today. And most recently, Healthcare Georgia awarded Mercer University School of Medicine to develop an enterprise data platform providing accurate and timely guidance to the healthcare needs of Georgians based on health provider workforce information, social determinants of health, economic indicators, and population health. As a result, it will allow rural communities to identify needs as well as evaluate for metrics, including successful interventions and programs. And listed are a few examples of direct impact that should be realized in Georgia as a result of successful execution of the data platform. So if you have any questions, I'll be around for the remainder of the day, or you feel free to contact me. And let's get started.
Great. Thank you, Samantha. I feel a little bit like a game show host up here, so I may just walk around. Let's get our first panelist up here. It's in the trenches panel. And while they're coming up, I'll tell you a little bit. Can you hear me okay? Everybody hear me okay? This is being recorded, and they've asked me to use the microphone. Is this the right microphone? This panel, it's always, all of the panels are fun to think about who we would invite to speak with us. And this panel is always the one that I enjoy the most because I work the most closely with CEOs around the state. And if you've seen one community hospital, I think there are maybe 52 in Georgia. I can't remember exactly how many, but it's over 50. And if you've met one community hospital CEO, you've met one community hospital. If you've seen one community hospital, you've seen one community hospital. They're all different. They come in all shapes, sizes, flavors. So part of the task of getting a gathering like we have here is to think about the different sizes of hospitals, some of the cycles of change that they're in, and so that they can have a conversation. Hopefully this is where this is going to go, that we'll pick up on a few topics, and then as they kick the ball around together and with us, we'll leave some time at the end of the session for you to ask questions. We have quite a few other very successful, very challenged hospital CEOs in the audience, any of whom could be on this panel. And so I hope, Tracy, I'm looking at you, y'all will save some really hard questions for these panelists. Also, by way of introduction, I'll just tell you a little bit. I'm going to let each of the panelists introduce themselves and introduce their hospital. But I will tell you a little bit about the communities that they're in. Roger Forgey, who is on the end and still buttoning up, is actually with Stevens County Hospital, which is in Toccoa, Georgia, North Georgia. And Roger's been there since October. Don't want to steal his thunder. I'll let him tell. And I think, Roger, you may have a few slides. You're going to go without slides. He had prepared some, but either way is good. Roger has developed a reputation as kind of might not like me saying this, but really a turnaround expert. He's been thrown into some very difficult hospital situations. The one that I'm most familiar with is over in Commerce, Georgia, and has seen them go from being underwater. And when you say underwater, just about every hospital says, well, what's the big deal there? I'm underwater too. It's not a question of that you're underwater, is how far underwater are you? Are you wearing one of those Bell helmets in the thing that lets you go, So Roger's been in that situation, has had success, and he's working on that, and will tell us about it at Stevens County. Tyler Williams, he's not a CEO yet, but he's unquestionably going to be one soon. He's a virtual chief operating officer at Habersham. Is it Habersham County Hospital or Habersham Regional? Habersham Medical Center, and he's really an operational guru and has been given whatever his title is. He's basically the CEO. He's reporting to the CEO directly, and he's getting all manner of things done. They're also, like just about every hospital, in a mode of let's make this airplane fly a little bit higher and not quite so close to the ground. Vicki Lewis is a very seasoned and very respected CEO at a larger hospital down in Coffee Regional Medical Center. I don't think you're qualified tertiary care. You're not quite there, but you're big in obstetrical and other units. And well, you'll be telling us all about it in just a second. And then Lou Semrad is in Jefferson County, Louisville. How many of you have been to Louisville, Georgia? A few of you have. How many of you know what it was first famous for is Georgia's first what? It was Georgia's first capital. You knew that before Milledgeville. And it's a historic, beautiful community. And Lou has his first CEO gig there, and that's one of the reasons he's here. He's been an executive in the healthcare space, often on the quality side and on the clinical side. He has an MBA and a clinical degree. And he's just done a fabulous job helping turn Jefferson Hospital into a better direction. So we'll start with Lou and let you do your own introduction for a couple of minutes about what you're doing, who Jefferson is, just general thoughts before we kick off some questions, and we'll go down the line.
All right. Thanks, Bill. I'm Lou Semrad, the CEO at Jefferson Hospital. I'm probably the smallest hospital on this panel. We're 37 beds. We have 4 rural health clinics scattered around 3 towns in Jefferson County. We employ 8 providers, 4 MDs, and 4 mid-levels. We have about 16,000 people in our county. We are rural Georgia. You know, we started out 18 months ago on, I think it was Halloween Day. First day, we were losing $200,000 a month. That's a lot of money. You know, the past 3 or 4 months, we've actually broke even and made a little money. So we've come a long way. We're not out of the woods yet, but I appreciate the opportunity up here and to get the thought leaders, and it's always good to get folks in the same room and talk about the challenges that we face in rural Georgia.
Tyler?
Thank you, Bill. My name is Tyler Williams. My official title is Director of Operational Support at Habersham Medical Center. I have been in that role since about the second week in November. I've only been in healthcare for about 3.5 years, so still relatively new to the field. Habersham Medical Center is a 53-bed hospital in the Northeast Georgia section. We also have a long-term care facility. We have a home health agency. We also are in the process of expanding access in our county by bringing in more physicians. There's a huge disparity in the level of physicians that we have versus the population in Habersham County. So we currently employ, I believe, 8 providers, 5 of which are physicians, 3 of which are nurse practitioners, but we're looking at expanding more. So.
Thanks, Bill. I'm Vicki Lewis. I'm the CEO of Coffee Regional Medical Center in Coffee County. We are an 88-bed facility, and we too operate a rural health clinic. We have a few more providers. We employ actually between physicians and mid-levels over 40 providers. Most of those are specialists, unfortunately. We are trying very hard to turn that and employ more primary care. I've been in Coffee County for about 3.5 years. I was recruited, like the others, to effect a financial turnaround. And I can say with the help of our board and our team, we've been very successful in doing that. We are certainly not out of the woods yet. We are a county with a lot of poverty, a lot of generational poverty, so we are really challenged by our payer mix, and certainly just by the general social determinants of health as well. So happy to be here and share our story.
And I'm Roger Forgey. I'm at Stevens County Hospital, Toccoa, Georgia. Population's about 29,000. It's a 96-bed hospital. All of us have beds, but we don't operate that many beds. But it's really a hospital that's pretty much been in the same place for 80 years and pretty much operates the same way it did 80 years ago. And so we're really having to bring that on board. When you mentioned $200,000 loss, I would kill for a $200,000 a month loss hospital. Because that's not usually what it is. I think we were losing about $800,000 a month when I came. Very difficult to operate rural hospitals in Georgia. Obviously, it's a payer mix issue. It's several other issues. We have about 12 providers that we employ there. A pretty good community, an older community. Well over 50% Medicare population community. And we're struggling with everything else rural hospitals struggle with in Georgia, and that is since everybody knows everybody and everybody's related to everybody, it's hard to go into a hospital like that and make the kind of cuts you need to make to get the hospital right-sized. I will say this, one of the things that we talk about, and I know all of us have experienced here, is that when we go in and the board say, can you turn my hospital? The answer is always, well, yes, but I just can't promise you what size it'll be when we get it back to break even. And that's difficult for smaller communities because we need a certain size hospital to serve a certain size population, and it's difficult to fund a hospital of the size that needs to support that population. So that's where we are in Stevens County. And by the way, Vicki and I worked together, tried to work together. We were about, 30, 40 miles apart when I was with Mayo in Waycross. And Tyler and I are about 14 miles apart now in Habersham and Stevens County. So
That's a great overview. Let me pick on Vicki first and ask her to sort of launch into just kind of unpack a little bit, if you would, Vicki, and then we'll get your colleagues and see how many of similar issues they're facing. What are the things that are making it a financial struggle for coffee? What keeps you up at night in terms of trying to tweak the cost side and then get the revenue side up? Because it's always that, right? There's only so much you can do on cost control without impacting revenue. And so what are some of the things that are top of mind for Coffee County?
Probably the most significant is our payer mix and how we're paid. We unfortunately right now are not under contract with the exchange product in our county. Blue Cross and Blue Shield has the only exchange product in Coffee County, and they would not enter into an agreement with us without threatening our commercial contract. And so we had made a very, very difficult decision not to contract with them. We are excited about 2019. There are some, Centene is going to be in the county, so I think there's some other opportunities for us in 19. Secondary to that, it's just literally the amount of health care that is needed in our county. We have tried very, very hard to meet the comorbid population and try to fulfill their healthcare needs, and that's been difficult. We were very fortunate to be able to participate in an IHI Better Health Lower Cost program. That was a grant program, and we really worked on obesity. We have a lot of difficulty with diabetes, I know all of you do, and the comorbidities that go with that around hypertension and obesity. And that costs us, unfortunately, a lot in admissions or readmissions. Like all of you, the poverty in our community is also a big challenge. We see about 35,000 patients a year in our emergency department, and unfortunately, some of those visits are for patients who are coming for medication. And I know, again, I'm singing to the choir, I'm sure, but those are difficulties. The other thing is just talent acquisition, physician recruitment, and talent management. I joke sometimes that I think there's something in the water in Coffee County. We've been very fortunate in that a number of members of our medical staff actually grew up in Coffee County. And so we are working closely with Mercer and Augusta University and actually Emory to try to recruit physicians who are training in Georgia to come back. And I'm thrilled to say that we just recruited an OBGYN who's finishing up his residency at Mercer and joining us this fall, and then an orthopedic fellow who actually also grew up in our community who's finishing up at Emory, and we're going to bring him back. Now that's not without cost. So what keeps me up at night is, we've got to have these physicians in order to sustain the hospital and provide the care for the community, but they want to be employed. So, it's a difficult situation for us. We've cost managed the hospital to the nth. We do have a bottom line on the hospital side, but on the physician practice sides, we don't. And a lot of the reason for that, again, is the number of physicians that we're employing. And we certainly fair market all of that. We try to do that as economically as we can. We run the practices as virtual private practice-like as we can and keep our costs down there as well. But again, there's just a cost associated to it. So for us, a lot of what keeps me up is, is that the right thing to do? Look at the specialties. We've also recruited peds in family practice, again, to try to get at the overall health improvement of our community. I think that the alignment of the incentives between the hospital and the independent physicians in our community is also a challenge. We have some independent physicians who are very entrepreneurial, and they compete with the hospital, frankly, and that's not necessarily helpful. And then as Roger pointed out, we also have just plain and simply a lot of competition. HCA now is in Waycross, and as you know, they have unlimited funds and are doing a lot of things in our community that are challenging. And then we also just have some very successful standalone hospitals. Tift Regional is nearby, and we have a lot of push from the Florida hospitals. The Jacksonville hospitals are very much in our market. They place specialists in our market and try to take patients back to Jacksonville, especially St. Vincent's. And again, those are challenges for us. And so our community supports us. That's very good. That's the positive thing. So we try to earn their trust and their loyalty and work with them in every way we can, and certainly align our incentives. The only other thing I would say is we work off a balanced scorecard. It's very, very important to us. We could talk about finance all day long, but it's very important to me personally and to our leadership team to balance our safety, our quality, our caregivers' quality of life, and our patient engagement. So we really use the 4 quadrants and balance them. So finance is not held up as any more important than the other things. So we've done a nice job on safety and quality too. And I can't say enough about our team. We have a great team.
Thanks. There are half a dozen things that you touched on that could be an hour-long discussion, but just a couple of them. Tyler, I'd also appreciate your overview of unpacking the good, the bad, and the ugly, but with a little emphasis on a couple of things that Vicki lifted up. One is the idea of, well, how much more cost-cutting is it possible to do? That's the first thing you look at when you take over and try to turn something around, which was not exactly a turnaround, but you're trying to make some significant adjustments at Habersham. How much more can you do before you get to the bone? And then once you can't really do a lot more with cost cutting, then what do you do? What are the things you look at that are either creative or that maybe will help you on the revenue side?
So I think that, yes, you can cut only so far, and one problem that I think that Habersham Medical Center had was that they cut a little too far in the fact that we started cutting service lines that were bringing revenue into the facility probably about 2 years ago, and all of this started when we entered into a letter with Northeast Georgia, a letter of intent, thinking that we were going to join their system. And at that point in time, I think that some of the individuals in our organization kind of rested on their laurels and thought that Northeast Georgia was going to come in and basically save the organization. So at that point in time, we were in a 100% save as much money as we can mode, because as long as we look better to Northeast Georgia, I think we could get a little bit better price out of it. So we let a couple physician practices go, we let a couple of surgeons go, and then we started letting some service lines go in the hospital side of things. So when that happens, yes, we've saved ourselves some money, but then fast forward, when the deal doesn't go through, what have we done? We've ended up costing ourselves some money. And I actually started out on the financial side of the house. So I started going back and pulling fiscal year financial data and started looking at the amount of money that those service lines that we cut and the physicians that we let go, and see how much money that they actually bring into the bottom line of the hospital. And I started seeing a trend that we had probably taken out a couple $1 million worth of net revenue to the bottom line. So when you factor that in, once you cut so far, then you have to start looking strategically at, well, what are we going to do now to bring that revenue back in? So strategically planning, we look at the market, we look at what the market needs, and we look at additional service lines that the people in the market could use. But also, like Vicki said, hospitals, or what she alluded to, is that hospitals need providers and physicians to operate. Just because we have doctors in the area doesn't mean that they're necessarily going to use our hospital, because Habersham Medical Center probably has about 30% of its primary and secondary market share. A large majority of the individuals go down to Northeast Georgia, which is just a 30-minute drive down a 4-lane road. It's very easy to get there. And normally once they get into that system, they never come back. So if we're not keeping patients in our system, we'll never see them again. So getting the correct providers in the area is going to be important, just as we look at adding additional service lines to the hospital. But it is a very delicate balance, because as you start signing these physicians and they all want to be employed, they have pretty high market value salaries, and when you look at that on a balance sheet, it's very hard to justify sometimes how you can pay that. So it's a delicate balance to contract with them, to get them on a contract that makes them want to work harder, motivates them, shall we say. So you give them a pretty safe base salary, but then you incentivize them to want to get out and see more patients and take care of the people. So it's a tightrope.
Lou, same question. Generally, what are the things, but also focus on that question of out-migration, which I think is going to come up again and again and again. There's just almost no hospital in a community setting that's not struggling with out-migration, and interested in what y'all have done at Jefferson and what you're doing, and to try to keep more folks coming to your hospital.
Right. So the way our county is structured, we're narrow and tall, and we're the north end of our county, we have 3 towns, and our one in north, one in central, and one in the southern part of the county. The northern town, Rennes, is about a half hour from Augusta. And so you've got 3 major universities in Augusta. That's quite attractive if you're a patient, because it's about 20 minutes down to our hospital, so you can go either way. And that's where we see the vast majority of our out-migration. The Louisville, the central town, and Wadley, the southern town, we pretty much dominate those zip codes. And so what we've done to address some out-migration and future issues is we have not focused so much on inpatient care. As we talked about earlier, you know, we have 37 beds, but on any given day, we have 7 or 8 patients in our hospital. So we will never have 37 patients in our hospital unless we have an epidemic or a crisis in Augusta, or last year with the hurricane when it was plotted to come up the coast. You know, we were in the section that we were going to get patients from Augusta. That never happened. So that's the only time we will ever have a full hospital. So our strategy long term, and Bill has the advantage of having sat through our strategic planning sessions and executive session, is to focus on grow outpatient care, really so that those folks don't have to leave the county and go to Augusta for some of their treatments. We recently took our outpatient physical therapy and occupational therapy department and moved them to a renovated building on campus, which, if I may digress, everybody in here has a Georgia tax liability? Yes? Does anybody not have a Georgia tax liability? Okay, so everybody except for Mr. Burton. So the state legislature and Department of Revenue has been very generous, and there's about 50 rural hospitals that have been designated to be able to participate in the Georgia Tax Credit Program. This program, very simply, as of this year, that they just bumped it up, you can donate, if you donate $1 to one of the eligible hospitals, you will get a certificate credit of $1 for your Georgia state tax credit. It's dollar for dollar, and remember, for you, those of you who do your own taxes, a credit is what you want because that comes off the bottom line. It's not a deduction. We raised $238,000 last year just in our county, and we are a poor county. Like I said, about 16,000 people, and we took that money and renovated this a building we had that was unoccupied on campus, and moved our PTOT department there now. And if you went into that building, you would think that you were somewhere on a street corner in Buckhead. Fair statement? Fair statement. Not in rural Georgia. But okay, maybe not Fifth Plaza. And since we've only been open there about a month and a half, so we've got some data, but we are already looking for an additional PT or CODA to bring in there, and we've just contracted with a PT student to tie her down. She's a local girl, and she'll be joining us in about 3 or 4 years. And so, you know, just that simple investment from local folks and expanding an outpatient service, we're already seeing tremendous growth there. That's phase 1. Phase 2, we're adding cardiopulmonary therapy. That's a service that right now people have to go to Augusta to get. We have physicians from surrounding counties who are already ready to let us know when you open it up, because we will start sending patients your way. So we're pulling patients from outside of our traditional service area. And then phase 3 is a wound care clinic in that building. We do it for half a day now, but we think there's tremendous growth opportunity there, again, to pull from a 6 or 7 county area, so those folks don't have to go into Augusta. So our whole strategy is to provide services where folks don't have to out-migrate, and then to offer services that where they have a choice to bring them back to the county for the local community.
Well, there's a little cluster. I'm going to underline a few things, and you correct me if I get it wrong before we move to Roger. One, and there's a backstory, kind of a Paul Harvey, the rest of the story. One, without the tax credit and that extra $250,000 they had to play with, none of this could have happened, right? So I give a lot of grief to the folks under the Gold Dome, but this was a good move, and it just got better this year. And this is really important because just like most things die by 1,000 cuts, these hospitals are going to survive by 1,000 shoulders thrown to the wheel of the wagons they're pushing. So that was a good thing that the General Assembly did to create this, and it was a good thing that they enhanced it this year, because if you raised $250,000 in Louisville, Georgia, at what was it, 80%, 90%, you know that was still somebody taking a 10-cent on a dollar hit. You'll raise more this year, and you know more what you're doing this year. So without the money, they couldn't have done that. But where did they put that money? Because it was found money to a certain extent. They put it on something that would change the hearts and minds of the people in that community, that would cause them to rethink, well, why am I going to Augusta? I can get a Starbucks over there. I can go down the street, and by the way, I can support my hospital. And this is the rest of the story. Jefferson County, their county leadership agreed, and not only agreed to do it, supported it and advocated for a 2 mils increase in their ad valorem tax to keep the hospital alive. The hospital, when Lou took over, it was on life support. It was either, the community was either going to pull the plug, the hospital would be dead, or they were going to vote onto themselves a 2 mil tax increase, which was significant. Not only did the voters approve it, they approved it by 80%. 80% of the voters approved taxing themselves to keep their hospital alive. This is one of the great stories of Georgia right now. Another community another hospital representing 70% of the voters voted to save the hospital. So, but you have to ask yourself, and we're going to get into Medicaid expansion and other issues, is that really the right way for us as a state to be trying to keep these hospitals alive? Forcing, because it's still an open question about whether and how. I've got another, I'm not going to name names, but I got another great community hospital I work with where we can't even get the county commission to agree to put it to the voters. And I've concluded that they won't put it to the voters because they've been paying attention and they think the voters will approve it. And they're not sure they want to impose that on some of the people supporting their political careers. That's my opinion. So, Roger, to this question of outmigration, to this question of how and what can you do to change the hearts and minds and sort of retain some of those people that are going out and impact on the revenue side. And you in particular, I really would like for you to spend a little bit of time since October talking about where you were, how you're still bleeding, you're still swimming in a sea of red, how you made the progress you've made, and what are the things that could potentially move the needle for you guys over there. And your needle's got to move pretty quick.
Yeah, I think there is all of us have a finite amount of money we have that we can lose before there is no money to lose. And in our county, just a year before I came, they had gone back to the county commission and asked the county commission for money. And they got a bond issue from the county. Now, this hospital's operated for 80 years. And so for 80 years, if you made a good living and never went to the county and said, hey, we're making a good living, how about a break on your insurance or whatever? And then you show up saying, hey, we're broke and we're going to close next week. And by the way, we have 600 employees and we're a $50 million business. We need some money. That's not a good way to show up at the county. And so you have to have a different conversation about how it is. And so that's tough in these smaller communities. So I do want to advocate, before I get into the rest of it, one of the things that you have to do as a rural hospital, you're going to have to embrace your county commissions. You're going to have to find out. If I went to my county commission today and wanted a millage increase, what I would get told is, Toccoa, Georgia, 1/3 of our county is national forest, and we don't have any. So we're already millaged up as high as we can go in order just to keep the services we got. So you're not going to get any millage, so what are you going to do? So that, just speaking of that, and I also have one other statement to say when Tyler was talking. Everybody that comes to me from outside, our hospital's looking for the option to have partners, as Tyler and them did with Habersham in Northeast Georgia. And everybody in rural America always says, hey, we're looking for a capital partner. Well, let me clear something up. There are no capital partners out there. Nobody wants to take over a rural hospital, spend $20 or $30 million capitalizing it to have it marginally break even or lose money. It's just not going to happen. And so we all, and counties do this too, we overestimate the value of our hospitals, the actual monetary value of our hospitals. All of the noise that goes on in that has a bearing on outmigration. What happened with Habersham, guess what? They were in the paper every day. Their county commission was fighting with each other. They were fighting with Northeast Georgia. That kills their business. When I go out and ask for, I didn't do it, okay? When I go out and ask for a $15 million bond, and this percolates in the paper for 3 months, it kills our business. We actually did a timeline to say what happened. Why have we dropped volume so much at this hospital? And the biggest drop we had was after a newspaper article that said, "Is your hospital code blue?" And we had a massive drop in volume. So what we're doing in these communities that's helping cause this out-migration is we're scaring the heck out of them because we're public hospitals and we have to report this all in the paper, and they don't know if we're going to be open next week or not open next week. They don't know whether to create a relationship with our doctor or go somewhere else. And so what we see is the younger population out-migrates, and the Medicare population kind of hangs out and tries to be good and loves us and does that. So that's what we're suffering with out-migration. In order to stop that, there's 100 things we can do. We found out that we weren't even using social media to recruit. Well, if I'm going to recruit a nurse in this environment, I'd better be using social media. We didn't have case management, so I can't control my length of stay. So there are blocking and tackling issues we had to do, but to the public, we have to figure out how to change the perception of what a rural hospital does. Vicki talked about quality. You had better be able to do what you do at the highest quality possible, or you can't compete, and you can't even go out there and talk about competing, because what they perceive is a marginal hospital with marginal service availability becomes their reality. So you have to go out and make sure that the public understands you got something to offer. For us, though, we have a lot of out-migration for the reasons that Vicki said. It's tough to find providers. It's tough to get people to come to the community and work. And so we have to take a different tack to this. And one of the reasons why I'm a big proponent of telemedicine is that somehow we have to bring the ability to access subspecialists in the community without having to foot the bill for the salaries for the subspecialists. We just have to be able to do that. I don't have to have a neurosurgeon in my hospital 3 days a week, but I sure would like to be able to pick up the phone or pick up a telemedicine link and physically talk to my neurosurgeon. I'd love to talk to an infectious disease doctor to find out if I can keep Miss Jones in the hospital with her infection like it is, or a pulmonary medicine doctor to find out if my ventilator settings are good enough or if this patient rises to the level of transport, and have that. And we don't do that. And our tertiary large hospitals typically haven't offered that in the past. And then one last thing I'll say about it is we typically, as rural hospitals, go to those larger tertiary hospitals and say, help, please help. Most of the time we're asking for a handout. What we really need to be asking for is a hand up. They need us to survive. They don't always know that, but they do need us to survive because we're their referral base. And if you kill the rural hospital, you frankly kill the goose that laid the golden egg for you as a tertiary hospital. And what happens is your margins go down, your hospital is full, your tertiary hospital, and I really say this when I think about Northeast Georgia, a full hospital on divert every day with a small margin and watching the margins diminish and wondering why those margins diminish. And those margins are diminishing because they got their hospital full of my patients. And they need to have that hospital full of patients at a level way beyond my patients. Let's say my admission's worth $5,000. Well, they're paying for subspecialty support 24 hours a day in their hospital. Their beds are $20,000 beds. If they've got my $5,000 patient or $20,000 bed, their margins are going to shrink. So we're having a difficult time relative to outmigration trying to convince our regional tertiary players not to be thieves, but to be partners with us.
Why have we not been able to make that case to them? Because I see the same thing again and again and again. The tertiary quaternary care centers get it theoretically, but they don't seem to get it in a way that they take action on it. What's missing in that communication? And your thoughts, Roger, and then Vicki. If you're seeing the same thing, Vicki, what your thoughts are on how to get that conversation going to be effective?
Well, fundamentally, they all have a different level of learning. We think, and I think wrongly, that tertiary and quaternary systems understand rural hospitals. They don't. Having come from a tertiary system, and everybody thinks they sit in a room somewhere. All of us in a rural hospital think they sit in a room somewhere and figure out how to put us out of business. They don't even think about us, okay, unless we stop referring patients to them. And then they typically rise up. But one of the issues that I think is really important, Bill, and it frustrates me across the state and across the world, is that we have, as rural hospitals, relied on these tertiary quaternary systems who don't really have the expertise. And we do it because we can't stop competing long enough to sit down at a table and figure out how to develop business that makes sense for our communities, that would retain patients in our communities and stop some of this out-migration. Tertiary quaternary systems really are much more competitive in that environment, and they can't stop competing long enough to step back and go, wait a minute, how am I getting these patients? And if they want to be everything to everybody, then stealing patients is the right answer. But for us in a rural hospital, that just creates a time and distance issue that's much greater to care. You know, I've always said this, I believe this, I used to run a helicopter program for years. Whether you live or die shouldn't have to depend on your zip code in 2018. And yet it does. And it does because we can't stop competing long enough to have an intelligent conversation about what's the right global health care plan for our people. That's my take.
There's a missing communication incentive, I guess, or alignment. Vicki, you're? Yeah.
I think tertiary hospitals really don't understand the dilemma of community hospitals. And I think it's plain and simply not sitting down at a table and just having a frank conversation. You know, we've tried to align ourselves with some of the critical access hospitals in South Georgia. Angela just walked back in the room. Clinch and Jeff Davis Hospital, both. We've really tried to align ourselves with them. And that alignment has necessitated communication. We're talking. We're actually, you know, looking at what each other's book of business is and trying to be sure that, you know, we're not competing in a way that's detrimental to any of the three organizations. And I can't tell you how refreshing that is. It's so difficult when I try to sit down with the folks, and again, I'm using St. Vincent's because they're in Jacksonville and they're not in the room, but they're one of the hospitals that really tries to do, again, a grab for patients in our community. And I've tried to sit down and talk with them, and there really is just a difference in the incentives for both organizations. More patients are better for them, and they don't really understand the impact of putting their specialists in our community and taking all of those specialty services away.
What are some examples of that?
Cardiology. They put an electrophysiologist in our community, and as all of you know, the EP procedures can be very easily done for the most part. Not the ablations and some of the things that need to be done in the cath lab, but the device adjustments, the device checks, a lot of the lab work and diagnostics, those can be done in a community setting. Those do not have to go to a tertiary or quaternary center, and they simply don't do that. We have a diagnostic lab in our facility. They could place pacers in our facility, but they don't. They take those patients to Jacksonville. So it's very, very challenging. And you know what else? It's so hard for patients to understand that.
Right.
They really don't understand why they have to go to another state, let alone, you know, a larger facility for something that's pretty simple.
Right. Tyler, thoughts?
Well, you know, speaking to what they said, I like to talk about collaboration in healthcare, and one of the reasons that I like to talk about it, and I'm going to localize it, not talk so much about tertiary care centers working with rural hospitals, but Habersham Medical Center was the recipient of the Rural Hospital Stabilization Grant in 2016. What that required us to do was form a community work group and get the key players of healthcare in our area in one room, sitting around a table talking about what everybody does. And it is an enlightening experience when you start learning who is who in healthcare in your area and what they can do and what services they offer to complement the services that you do to help keep the patients in the area. And when you start breaking down these walls of communication and actually start working together, you can start keeping some patients in the area because, we have an FQHC that's directly across the street. I know that the primary care physician ratio to population in Habersham County is 1 to 4,500, which is 4 times worse than the national average. So, I mean, there's enough patients in our area that we don't have to compete. So once we stop Once we take the word competition and turn it into collaboration, then we start working together. Okay, so you can do those services? Well, okay, we'll look at using your system versus referring them down to Northeast Georgia like that. So you can take that mindset and upgrade it to start talking to the larger organizations or the larger tertiary care centers and say, hey, we're really good at taking care of those type patients. You don't have to take care of those. Use your beds for what makes you the money. Let us keep what we need to keep in our area. That way we don't have to keep shifting these patients back and forth. But another issue with that is patients are more mobile these days, and social media plays a huge role in it. And not only that, but even the quality scores, which are publicly reported, and marketing and branding. Because if I'm driving in Northeast Georgia, in the entire region, if I see a Northeast Georgia Health Center billboard, I know it because I know their logo, I know their name, and the majority of their time, their billboard says they're #1 in something, and that sticks in my head. If I'm a patient in that area and I can drive past a facility to get to Northeast Georgia, I might do that just because it's stuck in my head that, hey, that's the #1 heart hospital in Georgia for X amount of years. So it's my choice to go down there. So we also have to work on changing the patient's perception. And to do that, we have to improve our quality scores and get good at doing what we do, and that is delivering care.
Lou?
So many issues.
Yeah.
For us, we've not approached any larger facility to talk about a relationship, and some of that is based on, as you know, my hospital was managed for 3 years by an organization that was really good at cutting costs and really bad about driving revenue. In fact, every year they were there, revenue decreased. So my board and the county has a very bad taste in their mouth about partnering or entering into some kind of relationship. I think long term, though, it's going to be a necessary fact of rural healthcare to have some kind of relationship with a larger facility. Vicki talked about the difficulties and discussions with Blue Cross, and if you've been reading the paper, Blue Cross and Piedmont are butting heads, and so much so that the governor has stepped in and told them to put the egos aside. So if Blue Cross butts heads with Piedmont, you can imagine what they would, how they would treat a 37-bed hospital. Take it or leave it or get out of our face. So I think and we need, for us, 10% of our business is Blue Cross, and so we need that. And our Blue Cross contract is 11 years old, and we are afraid to go to them and try to renegotiate because they'll take it up and here's your new one, take it or leave it, there's the door. And so several of our larger contracts are that way, where we're just scared to go knocking on the door. But I think long term, rural hospitals will have to partner with, whether it's Piedmont, HCA, MCG, Augusta University. Sorry.
I can hear Beth whispering over there.
Old school.
Good. No coaching the witness. No coaching the witness.
Yeah. It'll always be MCG, but we'll have to enter into some kind of collaborative partnership with a larger facility just to be able to flex some muscle in contract negotiations and to get some respect in order to survive.
Well, this is a perfect segue to the next topic, which is payment sources, and because your counties can tax, we can get some tax incentive dollars. You can do more creative things with telehealth and others, but I want to talk about the 800-pound gorilla in the room, which is Georgia, the state of Georgia's failure to expand Medicaid. We can dance around it. There are different ways. We can use different lingo, but there are real dollars attached to that ongoing decision that year by year by year continues to impact. In the biggest impact, it impacts Grady, sure. It impacts big hospitals, sure. But who is the most vulnerable to those impacts, and where are most of those Medicaid patients located among the two Georgias? So let me be the boogeyman and the bad guy. I'm putting it in the worst, what I think is the most accurate term, that it is a failure to bring billions of dollars into our state that would really benefit you. I'll be the bad guy. Y'all can talk about it in a nice way. But before we do, I do want to just say that your points about the need and the opportunities for collaboration and connectivity between the bigger players in your region and you is huge. If nothing else comes out of this, if some of us are inspired to go and renew those efforts, then it will be worth it. And my example is Kurt Stunkel. Kurt was on this panel that you're on last year, and he was talking about the success they had with Polk County. They went into Polk County, they negotiated a wonderful deal, and they were in competition for that with HCA, which really wanted to keep that hospital. And they struck a deal, and they, with their Floyd County dollars, built a new hospital, a brand new hospital in Polk County. When's the last time you heard of a tertiary care center doing that for an adjacent community? You know what, and Kurt was describing in various ways how successful it's been, and he was asked the question, what's your biggest problem? And he wasn't being a smart aleck when he said it. It's just trying to decide what to do with the money that we're making in Polk County and the positive impacts it's had for us. So if you get that alignment right, Roger, to your point, there's as much money to be had for the tertiary care center as there is for the, so that's an important thing to take away, getting it right. Okay, I'll shut up. Vicki, tell me about what it might mean to Coffee County if there was a Medicaid payment associated with what is currently now charity care cases that have what part of your population, how would that impact you?
It would impact us on an annual basis at about $3.5 million. Last year we budgeted for $18 million in bad debt. We are not quite a $100 million operation, so 18% bad debt. We came in at 21 million, in excess of that, in bad debt. I mean, that is just a killer for us. So the failure to expand Medicaid has been a big detriment. We're the safety net. There are 44,000 residents in our county, and we are the safety net for those residents. Unlike a lot of counties, we operate the EMS, and we do operate a rural health clinic. The only tax dollars that Coffee Regional receives are splashed, and we get $400,000 a year in splosh dollars, which we can apply to ambulances. It has to be used for capital. So for us, you know, it's a tightrope, and I think the issue too is that this Blue Cross exchange product. So not only did we have an extra $3.5 million in bad debt, but we are not a provider for those folks who are on the exchange. What we've tried to do is to go out to, again, Centene and also to Aetna. And on the Centene side, they're looking obviously at providing an exchange product in our community. And Aetna is looking at providing an individual policy and a small group policy for folks as an alternative to the exchange, which again is just a good opportunity. We have a very large percentage of working poor in our county who have a job, but they're on Medicaid. They don't have any other source of insurance. I'm sure all of you are aware that I believe that Medicaid recipients in Georgia include about 70% of them are working. So that just, again, creates a dilemma. There's no ability for those patients to pay any portion of their care. And there's no ability for us as a charitable institution to deny them care, when we would never do that. But I think we do have an obligation to try to make the community healthier in a cost-effective way. And
well, I think
some days I feel like I'm running out of ideas on that.
I think the takeaway point is that there are things that can be done at a policy level, at the state of Georgia level, and at the federal level that could have a hugely impactful, even things if it weren't such a starvation diet out there from a financial compensation, you might be able to have more effective conversations about how to align better. But now it's a every man for himself, catch as catch can kind of world, because
for paying patients. I mean, what a mixed up world we live in. It just creates competition. I mean, you look at CVS buying Aetna, you look at, you know, the upside down world we live in. Well, here we have all these nonprofits, all these well-intended community hospitals, you know, competing for paying patients. I mean, I don't go to a meeting where CEOs aren't talking about what service line could we develop that's going to attract insured patients. I mean, that is just not the way to run a community hospital, in my view. I get it. I understand why we're doing it. I've had the very good fortune of working in 2 states that have a different Medicaid approach. The state of Ohio obviously accepted the Medicaid expansion, and I also worked in Wisconsin just before coming to Georgia. And while Wisconsin didn't accept the national expansion, they moved up to over 200% of poverty, the income level for folks who could qualify for Medicaid. Hospitals in those states are doing well. And hospitals in those states embrace, as you point out, the policymakers. They've really tried to communicate with them. I think there's been a lot, just a different kind of dialogue. And I don't want to be political about it. I don't mean that. It's just a different dialogue about what it's going to take to provide health care in those states.
Maybe that's another set of conversations, to try to be more effective in communicating at the state policy setting level what the needs really are.
No, that's well said.
Roger?
Well, I mean, you know, I'm going to retire after this assignment, so I don't mind.
No,
being
you're not.
political.
No, you're not.
Being political doesn't bother me, but Vicki's my numbers are almost identical to Vicki's numbers and what it would mean to me with Medicaid expansion. I do not understand it. It's free money. I'm sorry. I don't have any way to understand why we're not doing that. And it is political, and it's unfortunate. It would be the difference for me being able to be profitable or unprofitable. My position at the table to be heard by a tertiary center or anybody else improves dramatically if I'm profitable. If I'm unprofitable, I'm hearing what they are willing to do for me. If I'm profitable, we can have a dialogue. But there really isn't a dialogue. You know, it's the golden rule. He who has the gold makes the rule. And that really is the difference for me, is the Medicaid expansion. I don't understand it. I think we've left way too much money on the table for way too long.
Similar sentiments, gentlemen? Anything different?
Smaller numbers for us,
Yeah.
because we're smaller. But for us, you know, I'd pledged to, you know, ignore the governor's decree, and we're going to expand Medicaid in Jefferson County anyway.
How are you going to do that?
You know, being more effective. The management company that managed us previously and the folks before that really, for whatever reason, never saw fit to have a program that would help people determine if they were eligible for Medicaid and then help them get enrolled in Medicaid. And our health department, they'll help you do that, but they have, from what I've been told, about a 75% failure rate of paperwork being rejected, not because the person isn't eligible, but because the paperwork gets filled out wrong. I mean, that's horrible. And so we went from an inpatient status of about 5% Medicaid, and you know, we're one of the poorest counties. We're one of the health rankings came out recently, and Jefferson County is 5th or 6th from the bottom of 159 counties. So, so we've partnered with a company, and so everybody that comes to the hospital and registers either inpatient or outpatient, we check them to see if they're eligible, if they don't have insurance, to see if they're eligible for any assistance programs, either state or federal. And we have more than doubled. They started late last year, and looking at January, February, March numbers, inpatient status, we've gone to 11% Medicaid. And so where we were at 5, so we're expanding and with these folks, and I think we can do better. And so that's just the inpatient. You know, the outpatient is a similar story, and it's even bigger numbers. So we just kind of make sure that we're being effective doing
Gathering the low-hanging fruit.
And then, you know, lobby when we can, but you know, we're going to take action by ourselves.
Tyler?
So yeah, Medicaid expansion would have definitely helped our facility. I'm going through the numbers right now in my head, and probably based on the percent of people who use our facility, currently 30% of them are Medicare patients. We have about 10%, which we consider self-pay or uncompensated care. However, those 10% of individuals probably rack up 1/5 of my charges for the entire organization, all of which, or the majority of which, goes into bad debt. One of the reasons that they are doing this, though, is because they are getting their charges in the ER, which is the most expensive place for me to offer care. So now we can talk about appropriateness of care. So even if we expanded Medicaid, we wouldn't be using it appropriately because they would probably still be coming into our ER. So we need to develop the infrastructure and educate these individuals on the correctness and the correct level of care. This was one of the things that we had to look at for the rural hospital stabilization, and one thing that we actually did was we started a medical screening exam, and to make sure that people who go to the emergency room are true emergent patients. And to date, we started this June 1st of 2017. We've reduced our ER visits by 12 to 15%, reduced our ER charges by about 8% in comparison to this time last year. What we've also seen is that the average visit cost in our ER has gone up from being $1,100 to closer to $1,500 now, because the more acute patients are in our ER. But in doing so, we also had to expand the hours of our walk-in clinic, because I couldn't take access away from individuals and not give them somewhere else to turn to. So we looked at the arrival time of all the patients to our ER and found out that it was pretty steady throughout the day until 11 o'clock at night. So we also expanded our walk-in clinic to 11. So yes, Medicaid expansion will help, but I'm all about making sure it's at the appropriate level also.
Right. Well, I tell you, I always love this In the Trenches panel, because it's so fascinating, and we could go on forever. I do want to give the audience time for questions. We've got another 6-7 minutes, so let's see, back in the corner.
Hello everyone, Bob Silverstein, Specialist Telemed, and we're a large physician organization. We're not part of a large tertiary center. So how can we, as the physician component in telemedicine, and there are some partners here, I know that the climate has changed a little bit. We even have competitors that are now our partners here to help. Mac will be one of the ones talking today in terms of how we can help bring these specialist service lines to your hospitals. And I think telemedicine has grown enough, and we've reached enough critical mass that we can affordably offer it to some of the rural healthcare hospitals. Because as Tyler talked about the cost of service lines and physicians, and the physicians know their value out there. So we'd like to be able to. We've got our cards here. We'd like to be able to help you guys, keep the patients in the community. And in terms of the tertiary centers, it's important to work with them, but they tend to become the people that suck all your patients away. So we'd love the opportunity to work with you guys.
Great question. So anybody on the panel, it's a question of what are you doing with telehealth now to fill that need for subspecialists? What are you thinking about doing in the future? Roger, I know you and I have talked about it some.
Yeah,
You mentioned neurosurgery and spine. Who does neurosurgery with a robot and telemedicine? Well, 90% of those types of patients can be consulted with a neurosurgery tech at your local hospital. So those are some of the things.
it's a public perception issue too, and it's a professional perception issue. I mean, I was a medic and a nurse practitioner, and somewhere I picked up a clipboard and became an administrator, and my staff, Kathy will tell you my mutation is complete. But even I, after many years in doing in the clinical world, really felt like telemedicine was a bit hokey. That's not really good. We can't really do that in a distance way, until I used it and thought, when I can look into the pore of his, of the skin, if I can take my blood pressure and all those things via telemedicine. So it's much more sophisticated. Our communities don't know anything about it. I don't think they're the problem. I think we're the problem. And that's got to do with that connection.
I just so we can have more questions, that we could go on. By the way, a plug for the next panel, Big Ideas panel. It's got some really interesting concepts about telehealth. Every one of you are either doing a lot of it, doing a little of it, or looking at doing more of it. I don't know any leading CEO that's not. Question back, Tony?
Good morning. I'm Tony Miles from the College of Public Health here in Georgia. And one of the things I focus on is chronic disease management, healthcare delivery. Can you guys comment? Many hospitals in Georgia are losing money because of the 30-day readmission thing they get from Medicare. And one of the things that I work on is how to lessen that revolving door. So can you guys talk about that at all, how it affects your bottom line?
It's a big detriment to our bottom line, obviously, because of the penalties. We've done a couple of things really successfully. One of them is a community paramedicine program, because we operate the EMS. We have a couple of awesome paramedics, one of whom happens to be a nurse as well, and they do well-being visits and paramedicine visits that really help patients take their medication, be compliant with the medical plan of care on discharge. And we celebrate our successes. We do 30-day and even 60-day celebrations because we've got some real hot shots in the paramedicine program who've done a wonderful job. We've also done a meds to beds program. We obtained a retail license for our pharmacy, and we deliver beds to the bedside of patients before they're discharged. Again, as I think I earlier mentioned, many of our patients come back because they haven't taken their meds. I mean, they may go to the pharmacy and get their pain med or their psychotropic filled, but they don't go get their blood pressure medicine or any of their heart pills. And then they come back to the ER in 10 days and say, I'm here for my meds. And sometimes that results in a readmission. So the meds to beds is a little new for us, but we really think that's going to be impactful. And then the other thing, and this has been kind of an aha for us, we've got our physicians very involved in case management. We developed a physician champion who's worked with our case managers, and he has just blossomed. So again, another success to celebrate. He's done a really, really great job of working with patients around the medical plan of care.
Do you think that will help your bottom line?
I do, yeah, absolutely. We absolutely do. The meds to beds actually generates a little bit of revenue in addition to keeping us out of the penalties. And I think it also, the paramedicine program and the case management have helped us identify at-risk patients, either comorbid or patients who are living in poverty. Many of our patients come back to the hospital in some cases for a meal or for medications. So we really try to address, some of the nutrition and food issues of our patients through case management, and that in and of itself has prevented some readmission. So great question.
Excellent. I think we have time for one more question. Yes, sir.
Bill, I just wanted to comment on the situation of Medicaid in Georgia, and there's a huge catch-22 involved with that issue. I'm Doug Henry, and I'm on the hospital authority in Habersham County. I'm Tyler's boss. The problem is that the Medicaid expansion or the resistance to it is because of one word, and that's Obama. And the problem with the situation in particularly rural Georgia is predominantly Republican. They're not going to, our hospital authority, and I have a lot of experience with that, is not going to contact our legislator and say, hey, expand Medicaid.
Right.
Unfortunately, they're not going to do that. And heck, Governor Deal lives in our county. Do you think our authority's going to invite Governor Deal and talk about Medicaid expansion? They're not going to do that because our authority
It's the reality of it, yeah.
Republican. So it's a catch-22, and I don't know the answer.
Yeah, I think you've just put your finger on a really huge issue, and there's no getting around it, and that's why I said, I'm just going to put it very bluntly, I think there is no getting around the sort of the misalignment in ideology, which can be very political, and the practical reality on the ground. And we've got to create some pathways so that conversation can occur. I understand the ideology, and this is a long conversation. So I want to take a moment. I know we're all going to give some applause, and I hope a lot of applause. You can see how big the challenges are that they're facing. For them to take a day, or in some cases a day and a half off, and come to be with us to share this story. Those of you who have heard something that you want to follow up with, they may not all be here all day long, but you should grab them and have hallway. I've heard Robin Rao, who's here in the back, and many others who are here today who are repeat offenders who keep coming back. I think part of it is because you make connections. Doug's comments, for example, you get ideas, and so be sure you take the time to connect if you can during the breaks, and help me thank these people for giving us their insights today. So we have a short break, and please try to come back at 11 sharp. We're going to start at 11 sharp with the Big Ideas panel.